Good morning, good afternoon, good evening, students. Welcome to chest pain. So the objectives of this talk would be that we should be able to list differential diagnosis for chest pain across the systems. We should be able to evaluate a patient with chest pain using 4 steps of epilogical approach, and we should be able to order appropriate labs and imaging tests for clinical evaluation. Lastly, we should be able to recommend treatment based upon our diagnosis. So as you know, chest pain traverses across the systems, and there are multiple systems that chest pain can involve. So the first one, the most significant or the most important one, is cardiovascular system. Then there can be diseases in respiratory system that can cause chest pain, in musculoskeletal system. Then also there are gastrointestinal diseases that can present with chest pain, and then we also have some dermatological conditions that can cause chest pain. Then we have psychogenic problems that can present with chest pain, and lastly we can always blame everything on drugs. So there are specific drugs, especially cocaine being one, can cause chest pain. We'll talk more about it in detail later. So this is just a snapshot to give an overall view or picture of causes and diseases of chest pain. So this is just a very high level slide that shows high yield findings and most significant and important symptoms and chief complaints associated with chest pain whenever people have all these different diseases. We'll come back to it, so don't worry about it too much. The best way to utilize this material would be to go through the entire DSA and do not skip any part. Do not just look at the slides, actually listen to the audio, because there is a lot of information here and I'm trying to just capture it all together and bring it all together. Most of the quiz questions will be based upon the audio, so please do pay attention. Let's get started. So the first disease that we will talk about would be cardiac ischemia or acute coronary syndrome. So acute coronary syndrome is just the umbrella term used to describe either ST elevation MI or non-ST elevation MI or unstable angina. Clinically, based upon patients' symptoms and signs, there is no difference between these three things. So they all look very similar, but when we do EKG and the rest of the tests, then we can see that there are some differences. That is why it is all lumped together in the form of acute coronary syndrome. And then also there is something called this is unstable angina, and then there is stable angina. So there is a key difference between stable angina versus unstable angina. Most of you probably already know stable angina is going to be chest pain because of cardiac ischemia, but it is because of a stable plaque. So the plaque has not ruptured yet, so therefore the pain is going to be very predictable. It's going to start after a very predictable amount of exertion, and the pain will stop after patient rests. However, whenever that pain starts to become more in frequency or starts to occur with more severity, or even starts to occur either at rest or at night, then we say that stable angina has converted now into unstable angina, and that's when the patient is at higher risk and is maybe at risk for plaque rupture and can even develop full-blown MI. So that is why we pay particular attention to unstable angina. Also, any angina, any new onset angina, any patient who comes in with the chest pain for the first time, which is determined to be cardiac in origin, is going to be by definition unstable angina. So keep that in mind as well. And there are implications based upon whatever you define your patient as far as the diagnostic tests are concerned and treatment is concerned. So the diagnostic tests are very different for stable angina versus unstable angina, and the treatment is of course also very different. So it's always important to make this distinction whenever we are evaluating a patient. So let's see what's going to happen whenever our patient presents with chest pain. Well, if we are considering an unstable condition or stable condition, of course, naturally the first good question, the first best question to ask would be duration of the chest pain, and then of course onset. So these two will be the highest yield questions. The patient will say in the case of acute coronary syndrome, or even in the case of stable angina, patient will say that they have chest pain which is dull, and it's usually gradual in onset. It's not very sudden. It's like a squeeze or tightness and gripping. It's usually left-sided or substernal, and then it can radiate to the left arm. Some patients have accompanied diaphoresis or nausea, so they can present that way too, but the classic characteristics of chest pain are right here. Now there is a small subset of population that can present with silent ischemia, so they really don't have any symptoms at all, and you are evaluating them for some other reason and they happen to have coronary ischemia. That subset population is diabetic patients and female patients. So about 25% of female patients or diabetic patients present with silent ischemia, so just keep that in mind. Therefore, whenever we are evaluating a patient for any problem and they have even very subtle signs or risk factors, for example diabetes, and if they happen to be female, we should definitely rule out cardiac ischemia. Then of course not everybody will just walk in with this problem. There are specific risk factors for cardiac ischemia, and these are right here. So your older patients, your male patients, diabetic patients, definitely, and also patients who have chronic kidney disease, a strong family history of cardiac ischemia, hypertension, strong smoking history. This is extremely important. Hypertension, and then also obesity, which has been recently determined to be a risk factor for cardiac ischemia. So all these things are important to keep in mind. So anybody who has these risk factors and now has chest pain, this becomes a higher probability on the list that this patient has cardiac ischemia because of these risk factors. Then another standalone risk factor is cocaine. So cocaine is a drug that can cause acute coronary syndrome. Usually it does not cause it by atherosclerosis or even coronary artery spasm. The mechanism of action of cardiac ischemia is that there is norepinephrine uptake inhibition by cocaine. So there is a huge amount of sympathetic overtone, and that is how these patients get heart attacks. Therefore, whenever we are treating these patients with cocaine induced ischemia, we should not give them any beta blockers, because there is going to be unopposed sympathetic drive by cocaine. Regardless, although patients may use cocaine and they come in with cardiac ischemia, in the long run, even then the biggest risk factor, if the patient is a smoker also, for long-term cardiac ischemia would be smoking. So cocaine does not cause lifelong or long-lasting injury necessarily as much as smoking will cause. Therefore, if you have to pick your battles between smoking and cocaine, you should ask the patient to quit tobacco smoking. Another thing to keep in mind is that we don't have any studies to show. There is no data telling us if cocaine has any long-term effects or not. So the jury is still out there for this. All right, so this was as much as about risk factors. Now let's move on to the next thing, which is going to be your diagnostic tests and cardiovascular exam. So the cardiovascular exam is going to be normal most of the time in patients with cardiac ischemia, and just based upon the typical chest pain and the history and the presence of some risk factors, we go ahead and do the EKG. We also draw troponins and CK-MB, and then cardiac cath. So just keep that in mind. We can do all these things, but the diagnosis is going to be quickly made based upon EKG, troponins, and history. For patients who have unstable angina and they are in an acute condition where the acute coronary ischemia is going on, you can either do cardiac cath to do a diagnostic and a therapeutic test, but if the patient or you can do fibrinolytics, but if the patient has stable angina and the plaque has not ruptured, and they are very stable and their chest pain has been very predictable for a long time and they are medically managed, they can under some circumstances go for stress test. So cardiac stress test is appropriate for those patients. However, if a patient has converted from stable angina to unstable angina, then in this case stress test will become inappropriate. Also, if a patient develops a new left bundle branch plaque and they did not have it before, and now you are evaluating them again, and that they have a history of stable angina, and you are going to go ahead and do stress test, but on a repeat EKG there is a left bundle branch block, then we should not do the stress test. So these are some important clinical points to keep in mind, because they become very important whenever you are seeing your patient and evaluating your patients. So the next is complications. So patients who come in with acute coronary syndrome and they have either ST elevation MI or non-ST elevation MI, they obviously have myocardial infarction and they are at very high risk for death. So it's obviously very important to identify and diagnose this condition. But even if the patient does not end up with significant mortality, there are some significant morbid conditions that can develop as a result of MI. So other than fatality, the important complications after MI would be either a severe MR, so a severe mitral regurgitation will be present. In that case, cardiovascular exam will be obviously not normal, so patient will have a murmur of MR. There can also be a rupture of the septal wall, so septal wall rupture can occur, which will cause immediate decompensation, hemodynamic instability, and patient may actually go into a shock. Another thing even more advanced than that is left ventricular wall rupture, so the entire wall can rupture. You can see that on echo, and this patient, even before you get to the echo, you will see the patient has already become hypotensive and is going to have cardiogenic shock. So these are just very grave complications of acute infarction. So whenever your patient does not look very stable, and although they have typical chest pain and you feel like you will be able to treat them fairly well, and you are taking them to cardiac cath and all that stuff, but their exam doesn't look all that right and their vitals are becoming unstable, then obviously these diagnostic points need to be considered. So definitely keep this in mind. So obviously you're not going to be able to diagnose these three grave complications with regular troponins or EKG or even a cath. You will have to do echo. So whenever a scenario comes up, then definitely think about doing a quick echo on these patients. So let's move on. This is an EKG showing cardiac ischemia. So you can see that this is just representation of what valves are involved. So we know that lead 1 and AVL is going to be more for anterolateral wall, V5 and V6 is going to be for lateral wall, V1 and V2 is for septum, 2, 3 and AVF are for inferior wall, and 3 and 4 are for anterior wall. So whatever the leads are involved, whenever you see any ST elevation, then you know that this patient has ischemia or infarction in those walls. Whenever a Q wave develops, then it's usually a sign of infarction, and usually means that infarction has occurred for about 48 hours or more. So Q wave is usually a sign of 48 hours or more duration of injury or infarction. And this is just a quick slide to show just to get the vocabulary right. So ST elevation is more than 0.1 millivolt elevation in more than two or more contiguous leads. So it's not just one lead. You're going to have to look at it in two continuous or contiguous leads. So 0.1 millivolt is one box, so it has to be more than one box. So for example, you can see here clearly there is some ST elevation. Depression is going to be where there is more than half a box depression in more than two leads. T wave inversion is going to be again more than 0.1 millivolt or one box or small box inversion in two or more contiguous leads. And then Q wave is basically two boxes deep and one box wide. Just keep that in mind, simple to remember, two boxes deep and one box wide. Or another more complex way to memorize it would be 1/3 of the R wave. So whenever you see a Q wave right here, so for example this is a nice Q wave, and this shows usually infarction longer than 48 hours. So after the EKG, of course, we draw enzymes. So what are the enzymes that we draw? The first and the most popular and common is troponins. So troponins are going to start rising early on, and then usually within a couple of days they reach their peak. So therefore within the first 24 hours we draw troponins Q8 hours. CKMB is another enzyme that is cardiac enzyme from the myocardium. It will start to rise and then will fall within 3 to 4 days. The third enzyme is LDH or lactate dehydrogenase. We do not pay too much attention to it anymore because it is very non-specific, and it can be high in many other conditions too. The only point to remember here is that cocaine induced cardiac ischemia will not cause any elevation of CKMB. So do not rely upon CKMB in that case if you're suspecting cocaine. The only thing to look at would be troponin in this case, and of course urine drug test that shows cocaine. Here is the quick treatment overview or acute management of cardiac ischemia. So of course, once you have decided that your patient has cardiac ischemia, it's a red flag situation. So any hemodynamic instability, or of course you will look at vitals for that. Typical presentation of chest pain or all the characteristics that go along with chest pain of cardiac nature will raise a red flag saying that you need to intervene right away. So what is the quick intervention for myocardial ischemia? MONA is the mnemonic to remember. So we do MONA right away: morphine, oxygen, nitroglycerin, and aspirin. In this, you can see that if a patient's pain is relieved by nitroglycerin, then this is another additional indication that maybe this was cardiac ischemia. If they don't get better, then this is usually a sign that maybe it is something other than ischemia, because nitroglycerin is a quick vasodilator if it's given sublingually, and patients usually have relief of pain. The other things also, of course, will relieve pain. Heparin is another drug that should be used intravenously if you're suspecting an unstable plaque and you just suspect that it's going to rupture very quickly and cause massive infarction. Heparin will stabilize it and will avoid the rupture. Reperfusion therapy, which is basically fibrinolysis in the form of usually like streptokinase. This is another very life-saving therapy that can be used, but has to be used within the first 120 minutes from door to door, or within 120 minutes of the symptoms. If the patient has had symptoms for more than 2 hours, then of course this treatment is not going to be very valuable. Also, this treatment has some complications associated with it, so we don't always use it. There are definite contraindications to reperfusion treatment. For example, it can cause hemorrhage, and if patient already has a risk of bleeding, then we do not use it. Last or definitive treatment is going to be CABG. So whenever you see there is massive atherosclerosis or plaque formation in the coronary arteries, then a CABG or coronary artery bypass grafting is going to be the definitive treatment. So this is basically just a quick overview, very high level overview of treatment of coronary artery ischemia. And then the last thing is benzodiazepines. Typically we do not use them, we do not like them, we don't want to give it to our patients. But if a patient has already used cocaine, then what more harm a benzodiazepine will do? This will basically just relax the patient and will give some pain relief if they have cocaine induced myocardial ischemia. So we can definitely use some benzodiazepines temporarily. Alright, so the next is, that was all myocardial ischemia. Now we will go ahead and talk about aortic dissection, and we already talked about that when we were discussing dyspnea, but here in the context of chest pain, we'll review it again real quick. So a patient will come in with tearing chest pain, very severe, very sudden, very acute, and it's a hyperacute condition. Patient comes in usually within a few hours, and they have sudden onset of chest pain that is radiating to the back, and then also they have shortness of breath along with that. On top of that, these patients are going to be very hypotensive. But before that, let's look at the risk factors. So what kind of patients are going to come in with aortic dissection? Well, these are going to be your patients with primarily uncontrolled hypertension, which is a risk factor, family history of Marfan syndrome, or their own personal history of syphilis, because syphilis causes aortic aneurysm. So we all know that. Now these risk factors may or may not be present, but usually at least one of them should be present, and most common is going to be uncontrolled hypertension, because it is just more common in general population. So anyhow, when these risk factors are present and patient's pain is like this, it's very severe and radiating to the back and very acute. On top of that, they have some hemodynamic instability. For example, they have hypotension, tachycardia, and tachypnea. Then definitely think about aortic dissection. They may also have decreased pulses, some differential blood pressure, and sometimes they show a murmur, but these findings are not necessarily going to be quite evident. So just on the basis of hemodynamic status and the characteristic finding of the characteristics of the pain, you can go ahead and do further testing. So what are the tests that we do? The test of choice would be CT scan of the chest, but of course you can do EKG and troponins. Now remember, in this case, EKG and troponins may be abnormal because there is going to be some ischemia, and that is what is essentially causing the pain too. But it doesn't mean that you just hone your diagnosis in here and you say, okay, this patient maybe just has an MI and I'm going to treat them with MONA and they're going to get better. Well, they're not going to get better. Actually, they may die very quickly if we don't diagnose the aortic dissection. So therefore, whenever you have this combination of symptoms with hemodynamic instability, then definitely do a CT scan of the chest. Another thing to kind of pay attention to here would be that you can see that hemodynamic instability in the setting of chest pain is also going to be present in patients with severe complications from MI, for example, the mitral valve rupture or the left ventricular rupture. So those patients are going to look very similar to this situation too. So and those patients will need an echocardiogram. So you can do CT scan based upon your clinical suspicion, or echocardiogram based upon your clinical suspicion if it makes you think more that it was an acute MI that has led to those complications. So this is just something to keep in mind, but regardless, you will not go wrong if you take quick action. So this is a quick just a picture that you've already seen, so showing dissected aorta, and then here is your again a slide showing that basically aortic dissection is not necessarily through and through dissection. It's a dissection of the lumen, so or luminal wall. So there is going to be a false lumen formed, and here is a CT scan. So this is what you will see, a very clean, I shouldn't say clean, very clear dissection here, and there is some here, and there is some coronal view, very linear dissection here. So these patients are going to be obviously very sick.